Am I audible now? I guess I am audible now. Let me know. Am I audible now? Okay, great. So I was just saying that we would be going in a format just like we used to do, one or 2 years back in an academy. So we would be doing the most important concepts that you need to know, and these concepts are also going to be helpful for NEET PG because NEET PG also, they are more inclined towards clinical stuff nowadays. Okay, so all those who are new here, you can follow me on Instagram. So we have 4 pages basically. These are the two main. So that's my main account, and that's the Medicine Academy, where you would be getting a lot of notes and diagrams, flashcards. Okay, so let's look at the case number 1. Okay, so this is the case number 1 where the patient is having fever, patient is having night sweats, back pain, weight loss, and the range of motion is restricted, especially the flexion. Okay, so if you can look at this image, what is this arrow pointing towards? So what is this arrow pointing towards? You can just type your answer in the chat box. What is this arrow pointing towards? Yes. So we can see these are the vertebrae, and along the vertebrae, what do we have here? What is this arrow pointing towards? Anyone? What do you think, guys? Mansi? So see, I want these sessions to be interactive, right? So you need to answer whatever you feel like. You can just drop a text on the text box. So Mansi, what is the structure, first of all? What are these structures that are, on the both sides of vertebrae? Okay, so you think it's an abscess, but where is the abscess? So these two structures that you are able to see, these are the Psoas shadows. So these are the Psoas shadows, okay? So look at this CT scan. Now this side, on the right side, we have a normal Psoas, and on this side we have a lesion. When you look at this lesion on the contrast enhanced CT scan, you can see that there is a peripheral enhancement. Peripheral enhancement, okay? And basically looking at the features, the clinical features of this patient, fever, night sweats, back pain, weight loss, okay? Especially if you talk about a recent immigrant. So in US, when do you call a person to be a recent immigrant? So when you are solving questions, you need to know these concepts. So when do you call a person to be a recent immigrant? So a person is a recent immigrant if he or she has entered US from the last 5 years only. Okay. So recent immigrant from a developing nation and patient having symptoms like this, having problem in the ambulation, the flexion is limited. So this is going to be a case of Psoas abscess. Psoas abscess, but when you talk about the most common organism here, while you're talking about a recent immigrant case, so what is the organism we are talking about? Anyone? So especially when you talk about India or other developing nations, what is the most common cause of Psoas abscess? Looking at the features, particularly fever, night sweats, weight loss. So these could point towards tubercular etiology, okay? So when you talk about the Psoas abscess, so basically we have two types of Psoas abscess. We have primary Psoas abscess and secondary. So primary, primary is spreading via hematogenous or lymphatic spread. But secondary means if this Psoas abscess is due to, a contiguous spread from the surrounding structures who are infected. For example, you have to know these conditions from where the psoas muscle could get infection. Okay, so contiguous spread. So contiguous spread could be via number one, Crohn disease patient. Okay, So, for example, if the patient is having diverticulitis, then talking about the pod disease. Pod disease is tubercular in etiology, and there are more than one vertebrae involved. Okay, then osteomyelitis of the vertebrae, pyelonephritis. So, can anyone tell what is the classical presentation of a patient having pyelonephritis? What is the classical presentation of a patient having pyelonephritis? Anyone? Yeah, Mansi, I would be covering concepts of both step 1 and step 2 CK here. So they will be like integrated. So what are the main features of pyelonephritis? So remember, whenever a patient is having pyelonephritis, look at the temperature. So fever. And very, very important, you also have to focus on the history. So we're going to focus on history of recurrent UTIs. Basically, when you talk about pyelonephritis is nothing but, due to the ascending infection. So that infection has come from the lower urinary tract, be it bladder, traveling via ureters into the kidney. So history of recurrent UTIs is very important, then fever, and then costovertebral angle tenderness. So costovertebral angle tenderness is very, very important in case of pyelonephritis. Now, pyelonephritis is kind of serious infection. So this is the reason why whenever you come across any pregnant female, so basically if you compare pregnant versus non-pregnant, so there are two things here. Whenever, a normal person, we are talking about a normal female, whenever there is asymptomatic bacteriuria, so that means routine tests were done, and on routine testing, urine testing, it was found that there is presence of bacteria. The bacteria are present here, okay? But the patient is asymptomatic. So in this case, you're not going to prescribe a patient antibiotics. But the situation changes when the patient is pregnant. How the situation changes? The situation changes in terms of, the kind of seriousness regarding pregnancy. Because while you are, having a patient who is having asymptomatic bacteriuria and the patient is pregnant, you have to give antibiotics in this case. So this is a very important point. So what is the reason why you are giving antibiotics to a pregnant patient for a UTI or asymptomatic bacteriuria, but you're not giving antibiotics to a non-pregnant patient? What is the reason? So why you're not giving antibiotics to a non-pregnant patient or the vice versa? Can anyone answer this? What could be the reason? Anyone? So why you are giving antibiotics to a pregnant female who is having asymptomatic bacteriuria? What's the need? Because she's already not having symptoms. So why do we need to give her antibiotics? The reason is that if you're not giving antibiotics, you are increasing the chances of development of pyelonephritis in this female, because pyelonephritis is nothing but the ascending infection. Okay, so you have to be very particular when the patient is pregnant. You have to prescribe her treatment, even for asymptomatic bacteriuria, right? For the prevention of pyelonephritis. So that's very important point here. Okay, so coming back to the main concept that we were discussing. So what is the most common organism overall when you talk about a Psoas abscess? Not particularly talking about a situation where the patient could be a recent immigrant, just like we talked here. Overall, the most common organism is the Staph aureus, okay? Or when you talk about the endemic or the developing areas, for example, India, okay? So we have a lot of burden of tuberculosis here. So Mycobacterium tuberculosis is actually the main organism that is associated with the Psoas abscess, right? Now, when you come across a patient who is having Psoas abscess, what you have to see is that the patient is going to, when you try to do a passive extension or internal rotation of the hip that's affected, the patient is going to wince in pain. So that's very important. And what is the investigation of choice if you're suspecting a Psoas abscess in a patient? And yes, if a Psoas abscess is large enough, you can feel a mass. Okay, so you can palpate a mass. The investigation of choice in this case is going to be the CCT abdomen along with the pelvis. Okay, moving on. So what are the findings? How you can describe this CT scan? So looking at this picture, and one more thing, when you have to compare CT scan with the MRI, you need to know that the first differentiation that you need to know is that the bones are going to appear white on CT. So at least know what's CT and what's MR. Okay, so this is a contrast enhanced CT scan in the axial section. So what you are able to see is a well-defined encapsulated hypodense lesion, and there's a peripheral enhancement. Okay, so you could be given this kind of wording when you are given a case of Psoas abscess. Okay, so looking at this area, so this seems normal, but here you are able to see a loculated lesion. Okay, so this is a hypodense, well-defined encapsulated lesion that is having a peripheral enhancement on the contrast enhanced images. Now, what is the management of Psoas abscess? How are you going to manage this case of Psoas abscess? Yeah. So number one, obviously it is due to, infective cause. So you're going to give antibiotics. But along with that, make sure you know this, especially, when you talk about step 2 CK, step 3 or clinical exams. So percutaneous drainage is indicated when the size of the lesion is going to be more than 3.5 centimeter. All right. Now talking about the case number 2. So look at this barium follow through and what you are able to appreciate here. So the area that's labeled as A, please identify that area. What is that? What's A? What is A? Anyone? Identify A. Yes, guys. What's A? So are you able to appreciate this feathery appearance? Yes, Mansi, that's jejunum. Exactly. So why you are calling it jejunum? So there are a few points that you have to keep in mind regarding jejunum. Okay. So jejunum is nothing but the continuation, it's continuing from the duodenum, number one. And second thing is it's having a feathery appearance. So why there is a feathery appearance of jejunum, this you need to know. Okay. And if you look at this, they have labeled it as ileum, right? And the property of ileum is that it is featureless. You're not able to see that feathery appearance here in the ileum. The reason for this feathery appearance of the jejunum, what is that? What is the reason behind this appearance of jejunum? Anyone? Why do you see this feathery appearance here? Yes, guys. What is the reason for the feathery appearance of jejunum? See, you need to know, you need to identify at least the normal structures. And then, supposing you are being asked these like the labeling questions, then you need to know the properties of these structures, right? So this is jejunum, and the feathery appearance that you are talking about is due to the valvulae conjunctus. Okay, so when you talk about jejunum is having the most numerous plicae circulars. Okay, so plicae circulars and the valvulae conjunctus are one and the same thing. So you can get either of these options. You can mark. Okay, then talking about the uh, feathery appearance due to these plicae circulars. What are these plicae circulars or the valvulae conjunctus? These are nothing but the transverse folds of the mucosa and the submucosa. And what are they doing? They are actually increasing the surface area for the absorption. Surface area for the absorption. Okay. All right. One question here. I told you that jejunum is, continuing from the duodenum. So what are the parts of duodenum? So we always tend to, remember duodenum as a C-shaped structure. So what are the parts of duodenum? How many parts of duodenum are there? This is the most basic information. How many parts of duodenum are there? Anyone? How many parts of duodenum are there? It's very easy. There are 4 parts. Okay. There are 4 parts. So number 1, number 2, number 3, and number 4. Remember. So when you talk about this number 2 is, the most important part of duodenum according to, the theoretical point of view. So why do you call number 2 as the most important one? The most important part of the duodenum. Yeah. The reason for this is because when you talk about the second part of the duodenum, we have an opening. In fact, we have 2 openings here. Number one is A, number two is B. So what is A and what is B? What is A and what is B? Yeah. So if you're being asked this as a labeling question, what are you going to mark A as and what are you going to mark B as? So Mansi, what's A? Name the structure. What's A? A is going to be the major duodenal papilla. Okay. So A is going to be the major duodenal papilla. When you talk about the structure B, that's minor duodenal papilla. Minor duodenal papilla. Now the importance of this major. So it's major due to a reason. Okay. So the importance of the major duodenal papilla is that the secretions from two structures, they are entering through this major duodenal papilla into the second part of the duodenum. Okay. So what are these two structures that I've drawn here? कौन सी secretions आ रही है? Number one, secretions from the common bile duct, CBD. And obviously common bile duct is carrying the bile. And this horizontal part, if you are able to see, which structure is fitting into the C-shaped loop of this duodenum? Can you tell? What's fitting inside the C-shaped loop of the duodenum? Anyone? So if you look at this structure, we have pancreas here. Okay, so we have pancreas. And if I especially talk about what's fitting in here, we have the pancreatic head. So the head of the pancreas fits in here. So I'll erase this. Okay, now tell me this horizontal part. This horizontal part is the main or the major pancreatic duct. So this is the main pancreatic duct. Okay, so obviously main pancreatic duct is going to carry the pancreatic secretions. The pancreatic secretions are being carried by this main pancreatic duct, and both these secretions are ultimately entering into the second part of duodenum through this major duodenal papilla. But there's a guard sitting over here. So there's someone that's regulating these secretions that are coming from the CBD as well as the main pancreatic duct. So what's that guard that's regulating the secretions coming from the common bile duct as well as the main pancreatic duct? Anyone? So who is regulating these secretions? Can anyone answer? So remember, these secretions, they are like being regulated from entering the second part of the duodenum, so the major duodenal papilla, with the help of sphincter of Oddi. Yeah, Jayant, you gave the right answer. So we have a muscular sphincter here. We have a muscular sphincter here, sphincter of Oddi. And there's also, okay, so I'll draw a diagram here. So look carefully. This is the major duodenal papilla. We have a muscular sphincter here. We have a common space here. We have a common space here that's receiving the secretion from the CBD as well as the main pancreatic duct. And this common space where these secretions are mixing up, this is known as the ampulla of Vater. This is known as the ampulla of Vater. Okay. Now, what is the function of the sphincter of Oddi? Sphincter of Oddi is controlling. It is preventing the reflux also. So imagine once the secretions have entered into the second part of the duodenum, we don't want these secretions to go back, right? So these secretions are being prevented from being refluxed by this sphincter of Oddi, this muscular sphincter. Okay, so one integration of the pharmacology, the ANS, okay? So what do you think? Whenever there is parasympathetic stimulation, what's going to happen to the sphincter of Oddi? Yeah. Okay. Even if you don't know this concept, just remember one thing. When you talk about parasympathetic, when you talk about parasympathetic, all the secretions are increased. Body में जितनी secretions है, be it salivary secretion, be it the sweating or the urination, everything is increased. The gut motility is also increased whenever there is parasympathetic stimulation. Okay. Now, when you talk about the sphincter of Oddi, or when you talk about a situation where there is, alpha 1 stimulation, okay, alpha 1 stimulation. So you have to be very careful while you talk about alpha 1 stimulation in terms of the effects, okay. So when you talk about alpha 1 stimulation, alpha 1 receptors are present in different locations, especially when you talk about the smooth muscle, be it the bladder neck, be it the blood vessels, right? And yeah, sphincter of Oddi is also going to be constricted whenever alpha 1 stimulation is taking place. Okay, so remember this. So secretions are going to be piled up till that time. So constricted. Parasympathetic effect and sympathetic effect you should always know. Parasympathetic is going to increase all the secretions. So whenever anti-cholinergic, parasympathetic and cholinergic, they go hand in hand. So they are the same thing. So whenever you are given cholinergic effect, that means parasympathetic effect. Okay, ये याद रखना है. Whenever you are giving cholinergic effect, that means parasympathetic. And when you are given anti-cholinergic, so that simply makes it anti-parasympathetic. So parasympathetic का उल्टा होगा whenever you are given anti-cholinergic effect. And obviously the opposite of parasympathetic effect is going to be the decreased secretions. So the salivation is going to decrease, the lacrimation is going to decrease, the patient is going to have dry mouth, dry eyes, and then the sweating is going to decrease, the patient is going to have dry skin. Sweat is a form of, a method of heat loss from the body. So the body's temperature is going to increase. So all these features are going to be there. Urinary retention is going to be there. Gut motility will reduce, and ultimately the patient could develop the constipation. So whenever you are talking about cholinergic, that means parasympathetic. Whenever you are talking about anticholinergic, that means against parasympathetic, the opposite. All right. Now let's talk about the next case. So look at the history. So this patient is having PPH. PPH is postpartum hemorrhage. So while the obstetrician was trying to do the manual removal of the placenta, the patient started bleeding profusely. And when you look at the ultrasound, you're able to appreciate that this structure, this is placenta. This is placenta. So what is shown here? Okay, what is the condition? Anyone? So looking at the history, postpartum hemorrhage, and the patient started bleeding while the obstetrician was trying to manually remove the placenta. So what could be the condition here? What could be the problem? Anyone? So this is actually the antenatal ultrasound. Okay, so you're able to appreciate that there's a fetus also. Okay, yeah. So gamer girl, you got the correct answer. That's placenta accreta. Okay, so that's very important for us to identify a placenta accreta. Basically, it is a kind of abnormal placentation, right? So whenever you talk about abnormal placentation, what are the types of abnormal placentation? And what is accreta, basically? Okay, so whenever you talk about abnormal placentations, you always remember three situations. We have accreta, we have increta, and we have percreta. And we have percreta. Three situations you always have to know. And what is the difference? So that's the most highly thing. इनमें फर्क क्या है? So what's the difference between accreta, increta, percreta? So Mansi says accreta is placenta adhered into the endometrium. Into the endometrium, okay. I guess the comments are like taking time to show here. Okay, so when you talk about accreta has to be differentiated from increta and percreta. Okay, so accreta is like whenever the chorionic villi are attached to the myometrium. अभी अंदर नहीं घुसे हैं, they have not invaded, they have not, penetrated into the myometrium. So the chorionic villi have attached to the myometrium. तो myometrium के साथ जुड़ गए हैं. They have not yet, invaded it. Accreta. So how did I remember it? In means going inside. So accreta is that the chorionic villi, they are invading or penetrating the myometrium. अब जो chorionic villi थे वो invade कर चुके हैं और penetrate कर चुके हैं into the myometrium. The third, percreta. So how did I remember it? Per means here perforation kind of thing. Okay. So percreta, the chorionic villi have invaded and penetrated the myometrium. यहाँ तक तो same था, accreta and percreta, but what's different is, okay, in case of percreta, serosa is also going to be penetrated. Okay, so serosa is also going to get penetrated in case of placenta percreta. Remember this. And it could eventually, in case, in very rare instances, this percreta could also go beyond the serosa. And it could involve the adjacent structures also. Remember this. Okay, so this is really important. You have to know what is the difference between these three. Okay, so placenta accreta, whenever you talk about the case that I showed you, there is going to be loss of placental myometrial interface on ultrasound. So there is a hypoechoic. So whenever you talk about the ultrasound, we will be talking about the terminology of hypoechoic, hyperechoic, anechoic, isoechoic, echoic. Okay, so this term is going to be, reserved for ultrasound findings. So here, whenever you talk about a hypoechoic, that means a dark line. So supposing there's a placenta here, there's a myometrium here. Placenta or myometrium के बीच में there is going to be a dark line. That's a hypoechoic line. And that's a myometrial placental interface. इनकी boundary है एक तरह से ये. And if you're not able to appreciate this retroplacental myometrial interface on ultrasound, that means placenta is sticking to the myometrium. Either it may be invading it or not, that's different, but yes, there's interface is lost. That means the placenta has crossed its boundary. Okay, so chorionic villi attached to the myometrium, not yet penetrated or invading it, this accreta. This we have already discussed. Okay, these three situations. And yes, someone is talking about the risk factor. The risk factor, previous LSCS. Okay, yeah, that's a risk factor. Okay, or previous uterine manipulation, that could also be, given to you. That's a risk factor for the development of abnormal placentation. Okay. One more thing. What's shown here in this ultrasound image? What is shown here in this ultrasound image? So on Doppler, you are able to see that there is extensive, blood flow here. The blood flow is increased. Remember, there are, if I remove the Doppler from here, the blood flow, you'll be able to appreciate the hypoechoic tortuous vessels. So there are lacunae present in the placenta. Placental lacunae are present. Remember this. Okay. Moving on. Now look at the next case. The part of it we already discussed. Okay. So the question here is, what are the two ducts of pancreas? What are the two ducts of pancreas that you know about? Anyone? What are the two ducts of pancreas? Yes? What are the two ducts of pancreas? Your answers are not showing up in this chat box yet. Okay, so when you talk about the two ducts of pancreas, we have main pancreatic duct and we have the accessory pancreatic duct. Ventral and dorsal, those are the buds. जो ventral dorsal buds की बात कर रहे हो, they are the buds. We are talking about the two ducts of pancreas. So we have the main pancreatic duct and the accessory pancreatic duct. Okay, so the one that I showed you while we were discussing that once that's coming, along the long axis of pancreas, that's gonna be our main pancreatic duct. Remember. So along the long axis of the pancreas, for example, so this structure that I've drawn here, this is pancreas. So there are different parts of pancreas. Okay. So here we have uncinate process, which is nothing but the extension of the head of the pancreas. Then this is head of the pancreas. Then we have the body of the pancreas. Then we have the tail. Okay, so can anyone tell me what's the structure that's retroperitoneal in the pancreas and what's the intraperitoneal structure in pancreas? So what are the retroperitoneal and intraperitoneal structures in pancreas? So that's also very, very important concept that you need to know. Anyone? So please type in your comments. What do you think? What are the retroperitoneal structures and what are the intraperitoneal structures related to pancreas? So I've shown you the different parts of pancreas. What are the retroperitoneal and what are the intraperitoneal structures that you need to know about? Anyone? Yes, guys? So remember, all the parts of the pancreas, they're gonna be retroperitoneal, except, see, exceptions are always important. सारे part pancreas के they are retroperitoneal, except which parts we are talking about? So we are going to talk about the tail, exactly, that's intraperitoneal. Tail is intraperitoneal structure. Okay, so when you're talking about the retroperitoneal structures of the pancreas, similarly, the other retroperitoneal structures are very, very important and they should be on your tips. Okay, so without even, looking at the answers, you need to know the list of retroperitoneal structures. Very, very important. So number one is the suprarenal. So suprarenal means we are talking about the adrenal gland. Okay, then we are talking about the aorta. Then we are talking about the IVC, that's also retroperitoneal. Then we are talking about the duodenum. So duodenum, all parts of the duodenum, they are retroperitoneal except for the first part. That's intraperitoneal. Then talking about the P. P is for pancreas, except tail. Except tail, that's retroperitoneal, okay? So then we have U for ureter. And then we have C for the colon, except transverse colon. So colon is having different parts. Remember, ascending and descending, they are retroperitoneal. Exception is the transverse colon. Then talking about the K. K is for kidneys. Kidneys are also retroperitoneal structures. Then E is for esophagus, the thoracic part of the esophagus. Okay, and rectum. A part of rectum is also retroperitoneal. ये जो mnemonic that's given in first aid, they have given a very nice mnemonic, sad pucker. So you have to remember this mnemonic, okay? Moving on, looking at the case number 5. So supposing you are being given histopath finding like this, the patient is coming to you and the patient is having cough, fever, rusty sputum. The cough is productive and there is rusty sputum. And the patient is post-splenectomy patient. Okay, so this is a very important hint that's actually given to you. So what do you think this is? They have also given you a hint, gram-positive diplococci. So what is the diagnosis here? Looking at all these information, so basically our goal is to, pick up the keywords from the question and ultimately arrive at a diagnosis quickly. So what is the diagnosis here? Anyone? So even if you don't know the this histological slide, you can answer this question easily. How you can answer this question easily? Because the question is giving you very vital hints about it. Number 1 is rusty sputum. Number 2 is post-splenectomy patient. These 2 hints are enough for you to call it a strep pneumo infection. Okay, so this is a case of streptococcus pneumoniae infection. So we are talking about step pneumo. Remember, why did I mention this post-splenectomy patient? What is the reason? What is the reason why post-splenectomy patient is mentioned here? Anyone? So basically, why we are, focusing on this concept of post-splenectomy, the reason is spleen is able to get rid of what kind of organism is strep pneumo. Strep pneumo is an encapsulated organism. Okay, so when someone is having a normal spleen is able to get rid of these encapsulated organisms. इनको body से निकाल देगी. But if someone is having post-splenectomy status, a post-splenectomy status, when it could be possible? Number one, if the patient is having road traffic accident and ultimately the patient got the splenic laceration. अगर extensive splenic laceration हो गई, ultimately we will have to remove the spleen. Okay. Second situation, it could be in the case of sickle cell anemia patient. So can you tell me why in sickle cell anemia patients we are talking about post-splenectomy status? What happens in sickle cell anemia? What happens in sickle cell anemia patients? So what you have to remember is in sickle cell anemia, there is autosplenectomy. There is a phenomenon of autosplenectomy. Why? Because if you compare a normal RBC, अगर आप normal RBC को compare करते हो with the sickled RBC, a normal RBC is having biconcave shape, okay, and it's very flexible. It's very flexible. But if you talk about a sickled RBC is a dehydrated kind of RBC, very stiff. This is not flexible. So what will happen? While these sickled RBCs, while the blood is flowing through very small blood vessels, okay, these sickled RBCs are going to clump over there and they are going to cause the vascular occlusion. They are going to block the splenic sinusoids. And ultimately, when you talk about the obstruction to the blood flow, there is going to be the atrophy of spleen. The spleen is going to get reduced in size, and ultimately autosplenectomy is going to be there, right? So these two situations you always have to keep in mind. And these are the situations where the patients are at increased risk of developing infections due to encapsulated organisms. Now, what are the other encapsulated organisms? So, the main or encapsulated organisms that should always be on your tips. Number one, step pneumo. Number two, Neisseria meningitidis. Number three, Haemophilus influenzae. Number three is Haemophilus influenzae. So we have three main encapsulated organisms that you have to always remember. Step pneumo, Neisseria meningitidis, and Haemophilus influenzae. Haemophilus influenza, remember, for type B only, we have vaccine. And that's okay because type B is the type that's actually associated with more invasive mucosal infections. So, ज़्यादा dangerous infection type B कर रहा है. So, invasive mucosal infections are caused by type B. That's fine because we have type B vaccine. That's a polysaccharide conjugated vaccine. Okay. So these are the three main encapsulated organisms that you have to remember, especially if you are being given a case of post-splenectomy status. Moving on, looking at the case number 6. So here you are given a patient who is having a foul-smelling fatty stools floating on the surface. And you look at this image. So identify what is being given. So foul-smelling fatty stools floating on the surface and the image. What's being given here? Anyone? Can you diagnose this? Just looking at the image, that's enough. Exactly. So this is a trophozoite of Giardia. What is the appearance? It is giving you the appearance of owl's eye. Yeah, so that's Giardia lamblia. Basically now they are calling Giardia lamblia as Giardia duodenalis. So the name has been updated. Okay. So even if you are being given Giardia duodenalis, that's the correct answer because this is the new name. Remember. So we have Giardia duodenalis. Previously, it was known as Giardia lamblia. How is it spread? Through the contaminated water that contains the cyst, or it could be also spread via fecal-oral route, especially in the daycare centers, right? How are you going to diagnose a case of Giardia? You're going to do a direct fluorescent antibody testing where you're going to identify the Giardia antigens. The treatment, very important. So, which drug you are going to prefer in case of Giardia infection, Giardiasis? The drug that you're going to prefer in case of Giardiasis is going to be tinidazole. Okay, more than metro. Metro is not the first choice. That's what's the take-home message here. Metronidazole actually is a drug that's associated with a lot of side effects. For example, most common side effect is the metallic taste that the patient gets. Okay, and along with that, metronidazole. One more point that you have to remember from exam point of view is that metronidazole should never be taken along with alcohol. So you should never consume alcohol while you are taking metronidazole. So what is the reason behind that? Why you should not be taking metronidazole and alcohol together? That's very easy. What's the reason? Anyone? The answer to this question is that it is associated with the disulfiram-like reaction. So याद रखना आपने metronidazole is the very important culprit in causing the disulfiram-like reaction. Okay? Why disulfiram-like reaction? Because it is producing the effect similar to what disulfiram does. Basically, disulfiram is a drug that's given in the alcohol de-addiction centers. Along with the alcohol, the patient is being given disulfiram. And while the patient is taking disulfiram, what's going to happen? The patient is going to have unfavorable side effects of alcohol. The patient who used to have a euphoric effect after consuming alcohol, if this patient is also being given disulfiram, the patient will start to have hangover-like symptoms. Patient will no longer feel the euphoric effect of alcohol. That's why disulfiram is being given in such cases where de-addiction has to be done. But similar effects of disulfiram are being seen when you are given metronidazole along with alcohol. Okay, so one more question here. Can you tell me one anti-diabetic drug, the drug for diabetes, that should also not be given along with alcohol? Otherwise, it will lead to disulfiram-like reaction. What's that? I'm sorry, my voice is like not proper. I'm having a bad flu. Okay. So which anti-diabetic drug, when taken with alcohol, will produce a disulfiram-like reaction? Anyone? Anti-diabetic or oral hypoglycemic agent taken along with the alcohol producing the disulfiram-like reaction. The answer to this question is going to be sulfonylureas. Sulfonylureas. So whenever you read anti-diabetic drugs, you have to know the patient profile for which they are going to be, preferred. For example, when you talk about sulfonylureas हर किसी को नहीं दिए जाते, right? Sulfonylureas, basically, there are few points that you have to know regarding sulfonylureas. Number one, they are increasing the endogenous release of insulin. Body में से insulin की release बढ़ाते हैं. Endogenous release of insulin. Second thing, they are associated with life-threatening hypoglycemia. So supposing someone is taking sulfonylurea and along with that the patient has skipped a meal, अगर खाना खाना भूल गया, or there's a long gap between the sulfonylureas and the meals, there's a long gap between two meals and the patient is on fasting state, there's a high chance that the patient could develop life-threatening hypoglycemia. That's very dangerous side effect of sulfonylureas. तीसरी चीज, sulfonylureas are implicated in causing weight gain. That's the thing we never want. Okay, so the kind of patient profile that could be benefited from sulfonylureas could be those very lean and thin patients. Okay, and comparatively young, so that they don't forget to, eat their meals, and they have to be very properly counseled regarding it. So sulfonylureas also don't have to be taken along with alcohol due to the risk of disulfiram-like reaction. Okay, so please know about the sulfonylureas classification also. That's important. Moving on. Now, where do you use this term owl eye? कहाँ कहाँ use करते हो? Number one, the trophozoite of Giardia duodenalis. एक तो ट्रोफोजॉइड ऑफ जियार्डिया डुओडेनालिस जो हमने देखा अभी, 2 nuclei are resembling the owl eye appearance. The second situation where you are going to see this owl eye appearance. What's that second situation? Exactly. So that's CMV. That's cytomegalovirus. Cytomegalovirus, maybe you are going to see this owl eye appearance. Third, very important, is the Reed-Sternberg cell. Where is the Reed-Sternberg cell seen? Exactly, Hodgkin lymphoma. Remember. So Reed-Sternberg cell is the pathognomic feature of Hodgkin lymphoma. बहुत important है, याद रखना. अगर Reed-Sternberg cell नहीं है, it's not Hodgkin. Pathognomic feature है Reed-Sternberg cell, and it is CD15 and CD30 positive. There are different kinds of Hodgkin lymphomas. For example, nodular sclerosis. For example, lymphocyte predominant, lymphocyte depleted, mixed cellularity. अलग-अलग तरह के हैं features of the Hodgkin lymphoma. Most commonly, when you talk about nodular sclerosis, that shows bimodal. So whenever you are given bimodal age group distribution, तो क्या याद रखना आपने? Always remember number 1 Hodgkin, number 2 very very important is the osteosarcoma. Okay, so gamer girl, I don't know why your messages are not being delivered. I have not done any kind of setting here. No setting changes are there. Okay, so you can try again. Yeah, so osteosarcoma is also showing you the bimodal distribution. So what do you mean by bimodal? Bimodal means there are going to be two modes, two peaks of ages where there is going to be the onset of these kind of diseases. Okay. For example, osteosarcoma could be taking place in a patient who is 10 to 30 years of age, and then osteosarcoma could also be taking place in an elderly patient. Similar is the case of this Hodgkin lymphoma. All right. Okay. Now look at this situation. And one more thing about the Hodgkin lymphoma. Hodgkin lymphoma patients, whenever they are consuming alcohol, okay, just like we were talking about the disulfiram-like reaction, association with the alcohol. Hodgkin lymphoma patient, whenever this patient is going to consume alcohol, चाहे वो छोटा amount ही alcohol का क्यों ना हो, even one single drink, that is going to create a lot of pain in the places where there is lymphadenopathy. Hodgkin lymphoma, what's happening is the lymphadenopathy is there, okay? Cervical lymphadenopathy is very common. But whenever this kind of patient is going to consume alcohol, the patient is going to have severe pain because alcohol is going to lead to the capsular distension of a lymph node. Capsule को distend करेगा, there is vasodilation due to alcohol, and this is the reason that the patient of Hodgkin lymphoma is going to have pain whenever this patient consumes alcohol. Okay, so your homework is to review what's the effect of alcohol in a patient who's having essential tremors. Okay, so when you read about different type of tremors, we have intention tremor, essential tremors. Okay, so you need to know what's the effect of alcohol on essential tremors. Moving on. So look at this CT scan in the axial section. So what are you able to appreciate here? Can anyone answer this? This is important. You need to know this. So what are the findings given in the CT scan here? Anyone? So is the integrity of the abdominal wall maintained? So I'll magnify it so that you can able to appreciate what's happening here. So look at the arrow. What is this pointing towards? So what's happening here? Anyone? देखो, there is a defect. So what this defect could be? This defect is not central. Okay. What kind of defect is it? So looking at such kind of picture, you can make a spot diagnosis. Okay. अगर यहाँ पे defect होता between the two recti, that could be diastasis recti. Okay. So rectal diastasis. The defect is lateral here. So this is a case of Spigelian hernia. Remember, this is a case of Spigelian hernia. Spigelian hernia is not central, it's a lateral defect. It's a lateral defect. Okay. So what you need to know is, first of all, the normal anatomy here. So if you are able to appreciate, this is a rectus abdominis muscle. Okay. Then we have external oblique, we have internal oblique, and transverse abdominal muscle. Transverse abdominis. Okay. Now, whenever such a patient comes to you, so look at the presentation. Central nahi hai. This is umbilicus. Here you are able to appreciate a bulge. Side pe bulge hai. Okay. So this is a kind of lateral defect. Lateral ventral hernia, which is also known as the Spigelian hernia. Right? So now you also need to know where is the defect. Kahan defect hai ye? The lower part of the interior abdomen, just adjacent to the semilunar line. You need to know between two structures, कौन से दो structure के बीच में there is a defect. So there is a defect between the rectus abdominis and the semilunar line. And you should also know about the medial and the lateral boundaries of the Spigelian hernia. So medially क्या है? We have rectus abdominis muscle. And what do we have laterally? We have linea semillunaris or the semilunar line. So whenever you are given picture like this, lateral bulge defect दिखा दिया अगर ultrasound पे or CT scan पे, okay? And this defect is not central, this is lateral. So this is going to be a case of Spigelian hernia through which the bowel loops or the mentum peritoneum could be protruding through it, okay? Moving on, look at the next case. So there's this 12-year-old boy having night pain in the knee. Swelling is present, tenderness is present, pathological fracture is there. What is the diagnosis and what are the associations? So what do you think? What is the diagnosis, number one, and what are the associations? So whenever you are given picture like this, you have to, look at different features. Any one of you? So what's given here? What's the diagnosis and what are the associations of this condition? First of all, look here. If I magnify this image, so this is a pathological fracture taking place. Fracture hai, or the distal end or the metaphysis of the femur. There are lucent areas, lytic areas, beach mein lucent areas hai. Okay. Now, along with that, if you are able to particularly focus on this area, there is a soft tissue shadow also. यहाँ पे soft tissue shadow भी है. So whenever you are, commenting on a lytic lesion in the bone or a bone tumor, अगर आप suspect कर रहे हो, always talk about the zone of transition. So always you have to talk about the zone of transition. So zone of transition is going to give you crucial hints towards the etiology of the condition. Zone of transition could be wide, zone of transition could be narrow. Wide zone of transition and narrow zone of transition. What do you mean by narrow zone of transition? So narrow zone of transition matlab, supposing this is the bone, this is a lesion and then we have a normal bone. यहाँ पे abnormality है, यहाँ पे बिल्कुल normal bone है. Wide zone of transition means the lesion is there, you are not even able to appreciate its boundaries. कहाँ से शुरू हो रहा है, कहाँ से खत्म हो रहा है, you are not able to appreciate that. Okay, so when narrow zone of transition is there, you can properly delineate कहाँ से pathology start हो रही है, कहाँ से खत्म. That's going to point towards the benign etiology. Most likely the lesion is benign. Wide zone of transition मतलब आपको पता ही नहीं लग रहा कहाँ से lesion शुरू हो रहा है, कहाँ खत्म हो रहा है. That means it's pointing towards a more malignant etiology. Malignant condition हो सकती है. Okay, so here the zone of transition is actually wide. आपको नहीं पता कहाँ से शुरू हो रहा है, कहाँ से खत्म. More pointing towards the wide zone of transition and malignant condition, right? Looking at the age group, 12 साल का patient है. Pain in the knee, swelling, tenderness, pathological fracture involving the metaphyses, and along with that, it's going to have a wide zone of transition, pathological fractures, right? So this is a case of osteosarcoma. Remember this, okay? So this is nothing but the same thing that I've explained to you right now. So this is a case of osteosarcoma. When you read osteosarcoma, the most important points regarding osteosarcoma. Number one, I already told you, there's a bimodal distribution. Okay, so there's a bimodal distribution. Second thing regarding osteosarcoma that's very important is that osteosarcoma associations. किन conditions के साथ osteosarcoma is associated? So number one, we have Lieframoni syndrome. Lieframoni syndrome में what happens is there are mutations in the TP53. You know, P53 is a tumor suppressor gene. Agar this is mutated, obviously the patient is going to have multiple cancers at a young age. So if you are being given, you know, hints like this, multiple cancers at a young age. Second situation that's associated with the osteosarcoma is the retinoblastoma. Remember, retinoblastoma, very important, is number one, the loss of the red reflex. Whenever you are trying to put the light in the eye of a patient, okay, we are talking about a child here, retinoblastoma common in children. So you're gonna see leukocoria. So red reflex is lost. And second important thing regarding retinoblastoma is two-hit hypothesis. There is two-hit hypothesis that you have to remember. And third situation associated with the osteosarcoma is the Paget disease of the bone. Paget disease of the bone. Okay, very peculiar thing regarding Paget disease of the bone. What is that? Only ALP is abnormal in Paget disease of the bone. आप जब भी बाकी parameters देखोगे, you're gonna see everything is normal. Vitamin D, calcium, and all that, everything is normal. Only ALP is going to be deranged in Paget disease of the bone. Very important thing regarding Paget disease of the bone is like increasing head size, hearing loss in an elderly patient. Okay, these are the findings that you will get, you know, that could point towards Paget disease. Head size में change होगा, hearing loss होगा patient को. That's very important. Okay, and in Paget disease, bisphosphonates are the drug of choice. Bisphosphonates are also being given for osteogenesis imperfecta. They are also the drug of choice in case of osteoporosis. So you should also know how bisphosphonates work. Bisphosphonates are inhibiting the osteoclast, ultimately leading to the bone formation, right? And yes, very important side effect of bisphosphonates. Anyone? So it could lead to atypical fractures of femur, avascular necrosis. More important is the... Okay, so someone is asking about the knee pain diagnosis. That's osteosarcoma. Okay? Remember this. Moving on. So look at these. Very important points. Normal skin flora. What do we have? Staph epidermidis. Normally skin में bacteria that's present is Staph epidermidis. Okay? Then normal nasal flora or present in anterior layers. Very important, Staph aureus. Staph aureus. Okay, I'll show you the image again. All those who have missed it. So this image has been taken from Radiopedia. So you can see here the lytic lesions are seen, pathological fracture is there, wide zone of transition is there, okay? So I'm going to explain this image again. ये सारे लिटिक एरियाज हैं बीच बीच में. Then this is a pathological fracture that's taking place. Okay, at the metaphyseal region, there is pathological fracture that's taking place. And along with that, the zone of transition is wide. पता नहीं लग रहा कहाँ से lesion is starting. Wide zone of transition. Okay, in a young boy, most likely the case is osteosarcoma. So we are talking about osteosarcoma. And one point that I was talking about, bisphosphonate के side effect क्या थे? Bisphosphonate के side effect, osteonecrosis of the jaw. Very important side effect, okay? Fourth association of osteosarcoma could be post-radiotherapy. Post-radiotherapy हो सकता है, bone infarction. Okay, so the main basically association are leishmania, retinoblastoma, and Paget's. Remember this. Moving on. What's the normal gut flora? We have E. coli, bacteroids. Okay, normal vaginal flora, we have lactobacillus. Dental plaques. Whenever you are given a case of dental plaque, which organism? Strep mutans. Okay. Normal oropharyngeal mucosa, flora. We have streptoviridans. Viridans group of streptococci. Now look at this situation. This table is very, very important. First of all, tell me why it is important. Why we are focusing on the catalase positive organisms? पहली चीज तो आपको लिस्ट सारी पता होनी चाहिए. We have staph, we have serratia, we have Burkholderia, we have Aspergillus, we have Candida, we have Nocardia. All of these, H. pylori, these are catalase positive organisms. And they are very important in terms when you talk about the chronic granulomatous disease. So chronic granulomatous disease comes under the heading of congenital immunodeficiency syndromes. So when you read different kind of congenital immunodeficiency syndromes, for example, we have Scott-Eldrick syndrome, then we have Bruton's, then we also have the severe combined immunodeficiency, okay, ataxia telangiectasia, Shirdiak-Higashi. All of these are the examples of congenital immunodeficiency syndromes, and one of that is chronic granulomatous disease. In chronic granulomatous disease patients, these patients are at increased risk of developing these the infections with the catalase positive organisms. Okay, very important because these catalase positive organisms, they are not going to let the hydrogen peroxide to be used for making the reactive oxygen species. Okay, so I'll show you this page again. Normal flora. All those who have missed. So let me know when to go to the next page. Shall we go to the next page? Yes, Seal, are you done? Okay, we'll move to the next one now. Catalase positive organisms की बात कर रहे थे हम. Now, when you talk about a patient of chronic granulomatous disease, okay, they are having problem with the NADPH oxidase. इसमें problem है. And NADPH oxidase is a very important enzyme implicated in the respiratory burst. So respiratory burst phenomenon, okay, we have very crucial role of NADPH oxidase, myeloperoxidase in enzymes के बहुत important role है. And NADPH oxidase is defective in case of chronic granulomatous disease. So respiratory burst is disrupted. So this hydrogen peroxide, which had to be converted into the reactive oxygen species, will be broken down by these catalase positive organisms into water and oxygen. So there is no one to kill these catalase positive organisms. This is the reason why such kind of patients, they get infection with these catalase positive organisms. Staph, Nocardia, Pseudomonas, Serratia. Then we have E. coli, we have Burkholderia cepacia. Whenever you talk about Burkholderia cepacia, you always have to remember one point regarding Burkholderia. It leads to lethal pneumonia or respiratory infection in the patients who have cystic fibrosis. Cystic fibrosis patients में तीन main organism you have to remember. Okay, so number one is the Pseudomonas. So I'll write it down on the next page here. Okay, so whenever you talk about patients of cystic fibrosis, you have to remember three main organisms. पहली चीज, the fundamental thing that you have to remember regarding cystic fibrosis is that all these secretions, they are becoming very viscous, very thick. Okay, there's a mutation in the CFTR gene. Of cystic fibrosis, number one, you have to talk about Staph aureus. Number two, you have to talk about Pseudomonas. Number three, you have to talk about Burkholderia cepacia. When you talk about Staph aureus, that's associated in causing pneumonia in children. So, बच्चों में pneumonia that's being caused in the cystic fibrosis patients, that's due to Staph aureus. When you talk about Pseudomonas, the adults who are getting pneumonia due to cystic fibrosis, that's due to pseudo. Burkholderia is associated with the lethal. It could take the life of a patient. Lethal pneumonia, lethal respiratory infections. Okay, so that's about the cystic fibrosis. And one more very important thing. Chest physiotherapy is very important in patients of cystic fibrosis. Chest physiotherapy का बहुत important role है. Why? Because it leads to the mobilization of secretions. When there is chest physiotherapy, all the secretions that were pent up, that were stagnant at certain points, will move so that the nidus of infection doesn't develop. So these patients need to get these chest physiotherapies very regularly. Then we also have drug known as Dornase alpha. Dornase alpha. So that's a DNase that's going to break the bonds in the secretions and ultimately help the patient symptomatically also. Okay, so that's very important. And what is the first sign of cystic fibrosis in a child? Neonate mein, what is the first sign of cystic fibrosis? That's gonna be meconium ileus. Meconium ileus means if the patient is not able to pass the meconium within the first 48 hours of life. पहले 2 दिन में अगर meconium, which is the first stool of a baby, if the baby is not passing this meconium within the first 48 hours, you have to think about this, okay? And in US, we have a screening test for cystic fibrosis owing to the prevalence of the cystic fibrosis in US. So what's the screening test in a newborn for cystic fibrosis? So a lot of students, they mark it wrong. So they usually mark it as the sweat chloride levels. No, sweat chloride levels is not actually the screening test. Newborn screening test nahi hai. Immunoreactive trypsinogen is the screening test. So immunoreactive trypsinogen is the screening test for cystic fibrosis in a newborn. याद रखना, this is not sweat chloride level or nasal potential difference. वो वाली चीजें नहीं है. We are talking about the screening test in a newborn. Okay. Okay. Now look here. Look at this flashcard. So whenever you talk about H. pylori, okay? So you remember triple. Triple से you remember three things. Triple positive, triple pathology and triple therapy. तीन चीजें सबसे important है H. pylori की. This is how you have to remember it. Number one, triple positive. What do you mean by triple positive? तीन चीजें positive होंगी. Urease positive, catalase positive, oxidase positive. तीनों positive होंगे. Okay. Then talking about the triple pathology. Triple pathology means there are three main conditions, pathologies that are being caused by this H. pylori. Number one, POD. So POD is peptic ulcer disease. Okay. So POD stands for the peptic ulcer disease. Then we have gastric adenocarcinoma. Adeno matlab that the cancer that's arising from the glandular tissue. याद रखना. So gastric adenocarcinoma. Then we have the mild lymphoma. Very peculiar thing regarding the mild lymphoma is that whenever you start treatment, जब आप treatment करते हो H. pylori infection का, it has shown that this regresses. So mild lymphoma has shown regression upon the treatment of H. pylori infection. Okay, so that's very important point regarding mild lymphoma. Moving on, and mild stands for mucosa-associated lymphoid tissue. Triple therapy, this is what we have for the management of H. pylori. Eradication के लिए है हमारे पास. Triple means 3 drugs. So number one is amoxicillin, then we have clarithromycin, then we have PPIs. Okay. We have quadruple therapy also where we add the bismuth. Remember. Now, supposing the patient is allergic to penicillin. Amoxicillin is a penicillin. अगर patient को penicillin allergy है, what are you going to do in that case? So remember, you're gonna replace amoxicillin with the metronidazole in that case. Okay. So if the patient is allergic to penicillin, what changes you are going to do in case of the eradication of H. pylori therapy? You're gonna change amoxi with metro. Okay, moving on. So look at this. Patient having recent dental infection, history of bacterial endocarditis, history of IV drug abuse, focal neurological deficits, and fever. What is the diagnosis here? So the patient is having recent dental infection, bacterial endocarditis, all these features. Okay. So what is the diagnosis here? Try to answer the questions, please. Anyone? Dental infection, IV drug user, bacterial endocarditis की history है. Now patient is also having fever and focal neurological deficits. So this is clearly pointing towards brain abscess. याद रखो. कोई recent dental infection, history of the IV drug abuse and infective endocarditis. Infective endocarditis के लिए always remember new onset fever and murmur. Fever and new onset murmur. Okay? पहले नहीं थे murmurs and the patient is also having fever. So that's pointing towards the infective endocarditis. Okay? And this is a case of brain abscess. Remember. Can you tell me what kind of necrosis takes place in the brain? Or an exception to coagulative necrosis. Coagulative necrosis could take place everywhere. Another point regarding the coagulative necrosis is that the cellular architecture is preserved. But what kind of necrosis takes place in the brain? So that's journal pathology integration here. Anyone? So Zeal, the screening test for cystic fibrosis in US is immunoreactive trypsin. Okay? Yes. Here the answer is going to be liquefactive necrosis. Remember. So coagulative necrosis takes place almost everywhere. It could happen, but it doesn't take place in the brain. In the brain, we have liquefactive necrosis. There are different kinds of necrosis. Please review that, okay? Necrosis is actually an irreversible injury. Irreversible injury. Moving on. So look at the history. We have a homeless patient. There's a history of recent immigration from Bangladesh. Patient is having cranial nerve deficits, weight loss, irritability, neck stiffness. What is it? So what are we talking about here? So homeless patient, history of recent immigration from the Bangladesh, then weight loss, irritability, neck stiffness. What is it? देखो, whenever you are given a case of neck stiffness plus developing nation, what do you have to think about? Tubercular meningitis. Neck stiffness आपको बता रहा है that the patient is having meningitis. Immigration from a developing nation is telling you about the tubercular etiology. So this is a case of tubercular meningitis. Yes, Doodler, you got the right answer. That's tubercular meningitis. And the patient would come to you with high fever, altered mental status, okay? These kind of features could be seen in case of tubercular meningitis, remember. Moving on, and the CSF glucose levels are going to be really low because mycobacteria loves glucose, okay? Now look at this image. So the patient with a cut or boil on his hand cooks food, other people eat it, get sick within 6 hours. What are the two DDs? So someone is having boil or cut over the hand. The same person is cooking the food, others are eating it, and they get sick within the 6 hours of consuming this food. So what is the differential diagnosis in this case? Anyone? What is the differential diagnosis in this case? Within 6 hours symptoms आ गए हैं. Very important. So this could have two possibilities. दो possibilities हो सकती हैं. Basically, the symptoms are occurring very quickly क्योंकि preformed toxins have done their work. Toxins already बने हुए हैं. Preformed toxins are causing problem. So it could be either due to Bacillus cereus or it could be due to Staph aureus. Very, very important. Bacillus cereus, what you have to remember is reheated rice. So never eat reheated rice. When you talk about Staph aureus, there are different uh, food items associated with that. So for example, mayonnaise, potato salads, ये सारी चीजें, they could be causing the food poisoning due to it, okay? So look here. When you talk about history of potato salad, mayonnaise, custard ingestion, or within 6 months symptom aa gaye, so this is going to be a case of Staph aureus food poisoning or foodborne illness. When someone is eating reheated rice, it is due to the Bacillus cereus, okay? And this is taking place due to the preformed toxins, okay? So what happens is, even if the person is consuming cooked food, cooking is going to kill the Staph aureus, but it is not going to kill the toxin. Staph aureus ko maar degi cooking, but the toxins are going to survive. Okay, so this is the reason why cooked food could lead to it. Okay, despite of cooking, also the patient could develop the infection. All right, so that's all for today's session. Okay, I hope you enjoyed this session. So I'll try to take it again on the next Sunday, coming Sunday. So we will be having a flashcard session. In fact, I want this to be like a quiz so that you can, type in your answers and then you can see if you have answered it correctly. And we would have, a few prizes also. For example, the flashcard giveaway and all that. Okay. So I'll be seeing you next week. And I hope you enjoyed the session. All those who have not followed me yet, please do so. So we have these two pages. Okay, and flashcard page also on Instagram. So please do follow us. Bye bye.